Okay, I have this one. Okay, I'll present. Okay.
10 minutes sort of discussion.
Okay. Correct.
Next session will be ACLF4, drug-induced liver injury in Asia-Pacific region. Moderators, please.
My name is Tatsuo Kanda, Nihon University School of Medicine.
My name is Graciela Castro. I'm president of Latin American Association for the Study of the Liver from Mexico.
He's in the
No?
mic. Please share the mic.
Okay. My name is Graciela Castro. I am president of Latin America Association for the Study of the Liver from Mexico.
Good afternoon, everyone. I'm Dan Yok Yang from the National University of Singapore, Singapore. Thank you for coming to this session, which is on drug-induced liver injury in Asia-Pacific region, including herbs. It gives me great pleasure to introduce the first speaker, Professor Rino Ghani from Indonesia. Professor Ghani needs no introduction to a parcel. He's the secretary of the Jakarta branch of the Association of Indonesian Internal Medicine Specialists and also holds many positions within the Indonesia Gastro Fraternity, and also is part of the executive council of APAS. Professor Ghani, over to you.
Thank you very much, moderators. Thank you for the opportunity to share our discussion with this Congress today. My task today is to bring you the drug-induced liver injury. This is my disclosure. Drug-induced liver injury, for the definition, the Chinese Society of Pathology give the definition of the recently give the definition of drug-induced liver injury. Refers to liver injury induced by all types of prescription or non-prescription drugs, including small chemical molecules, biological agents, traditional Chinese medicine, natural medicine, health products, and dietary supplements, or their metabolites, contaminants, and impurities. Drug-induced liver injury can be a cause of acute and chronic liver failure. In this case, the patients with underlying liver disease subsequently have a drug-induced liver injury. So this is a challenging diagnosis due to lack of gold standard diagnosis of DILI. The diagnosis is sometimes a precise medication cannot be point out, but from the exposure history, symptom onset, liver test assessment, and underlying liver disease can be excluded for the exclusion. So the study results showed that the drug-induced ACLF constitutes more than 10% of causes of ACLF in the Asia-Pacific region. And still, the mortality from drug-induced ACLF is high compared with non-drug causes of ACLF. We have many substances that can cause liver injury. Herbal and complementary medicine also included in these agents that cause hepatotoxicity. These agents can be used for the bodybuilding, blood weight loss products, for depression, for sexual performance, and of course for traditional medicines. Drug-induced liver injury is responsible as one cause of acute liver failure worldwide. More than 10% the acute liver failure worldwide can be traced to the drug-induced liver injury. The classifications of drug-induced liver injury can be intrinsic. In this case, drug metabolites itself that cause the hepatotoxicity. And this kind of drug liver injury is dose dependent. The latency may be for several days, and examples is the paracetamol, amiodarone, niacin, and methotrexate. The intrinsic cause classification or cause of a drug injury can also be indirect because of indirect injury by drugs altering liver or immune status. And dose dependency unknown, and latency may be in several months. Yeah, for example, is monoclonal antibodies, neoplastics agents, and besides that, drug-induced liver injury can be idiosyncratic because of host metabolic immune response, dose independent, latency days to years, and the examples is amoxiclav, cephalosporin, and nitrofurantoin. In Asia, common cause of DILI in Asia, it varies. In China, most of the common cause of drug-induced liver injury related to traditional Chinese medicine or anti-TB drugs. In Japan, it's anti-inflammatory and antimicrobial drugs. In Korea, herbal medications and also the medication that's prescribed. In Singapore, there is the Chinese traditional medicine or Malaya traditional medicines. In India, the anti-tuberculosis drugs is the most prevalent cause of DILI in India. And also in my country, in Indonesia, the most frequent cause of the drug-induced liver injury is the anti-TB drugs. As the hepatotoxic herbal and supplements, we know several things like ashwagandha or Withania somnifera. This can cause the cholestatic type of DILI. Even the green tea extract, also that used for weight loss, also can cause the hepatocellular drug-induced liver injury. Garcinia cambogia, also for weight loss, can also cause the hepatocellular type of DILI. Polygonum multiforum also can cause the hepatocellular or mixed type. And Schulteria baecalensis cause the hepatocellular DILI. Kratom, mixed type, and anabolic steroids also cause the cholestatic. Also turmeric, can cause the hepatocellular type of DILI. The severity of DILI can be categorized into 5 categories. The grade 1 no liver injury, the grade 0 no liver injury, and the grade 1 mild liver injury. In this case, only ALT mildly increase with mild increase of bilirubin without any consequences in coagulopathy. The grade 2, this is the moderate liver injury with increase of ALT and also bilirubin. In this case, the coagulopathy not yet disturbed, or if it is disturbed, without hyperbilirubinemia. Grade 3 is severe liver injury with increase of ALT and bilirubin also increased. The patient looks jaundice and with the coagulopathy with the ANR more than 1.5. Grade 4, this is the severe form of the drug-induced liver injury with acute liver failure, of course with the increase of ALT or alkali phosphatase and increase of bilirubin, and at least one of the following: the prolonged jaundice, sign of hepatic decompensations or other organ failure related to drug-induced liver injury. And the grade 5 is lethal. So when to suspect DILI? It's not really easy to point out the drugs as the cause of the hepatotoxicity. So the starting point is the patients after drug administration with non-specific liver injury with clinical manifestations and with the abnormal liver function test. Unknown liver injury with other common causes should be ruled out. And then history taking, stop the drug consumption, previous drug reaction, concomitant medication and effect onset of DILI, liver injury history, comorbidity, and an underlying liver disease, and also exclusion other causes of liver injury. In acute condition, in acute cases of acute liver injury, we should seek for the liver biochemistry baseline. If the liver biochemistry more than 2 times of baseline, that cannot explain by underlying liver disease. So the prescribed over-the-counter medicines, the other toxic chemicals or drugs should be seek for at least within 6 months. In chronic liver injury, this is more difficult to scrutinize, but unexplained prolonged mild elevation of liver biochemistry or unexplained findings of steatosis may be looked for and for the start of the examination. So in acute DILI, we can calculate the R ratio. R ratio is the ALT divided by the alkaline phosphatase. If R ratio more than 5, it's a hepatocellular. This is maybe exclude the acute hepatitis with the viral hepatitis should be excluded. Non-hepatotropic virus infection also, like in the Asia, dengue also should be excluded, and ischemic liver injury. In cholestatic type bile duct disease, also primary biliary cholangitis, cholelithiasis, primary sclerosing cholangitis should be excluded. And after that, if everything is already excluded and one of the drugs can be pointed out, this can be a clinical diagnosis. But if still cannot be determined, liver biopsy can be done. So causality assessment can be used RUCAM, but in case of not yet explained, liver biopsy is indicated. Liver biopsy indicated especially persistent liver function more than 3 months after the suspected drugs stops. We can look at the liver toxicity in other sources like the liver tox or hepatox to explain the agents that make the liver injury. For the causality studies, there is a RUCAM system, point system that can investigate the cause of the liver injury. But this ROCAM system is quite busy, yeah, with many things that should be filled out, and maybe this can not too popular to investigation of the liver injury. Japan already have a practical casualty study with the Japan criteria since 2004, and after 15 years is still good with only 8 factors. The first is time to onset. The second one is course. The third is risk factors, and the fourth is search for non-drug causes. And fifth is for previous information of hepatotoxicity. The sixth is the eosinophilia, and seven is the DLST. Then the eighth is the response to unexpected readministration. And if the score evaluation is less than 2, it's a low possibility. 3 to 4 is possible, and 5 is high possibility. And should we re-challenge? Maybe re-challenge is not recommended. So what is the treatment of DILI? The treatment of DILI, the key principles is timely diagnosis of suspicion cases of DILI, and then point out the offending agents that cause DILI and prompt withdrawal of agents. This is the most important things. And after that, specific treatment can be given, but only for a few agents, like cholestyramine can be given to the leflunomide or terflunomide-induced DILI. L-carnitine can be given to the valproate-induced hepatotoxicity, and also an acetylcysteine can be given to the patients with paracetamol-induced drug hepatotoxicity or DILI. Ursodeoxycholic acid may improve patients with cholestatic liver injury, and in case of DRAS, is drug-related eosinophilic systemic symptoms. In this case, steroid can be given. But any other drugs may not have a specific medication for detoxifications. So supportive treatment is very important. In ALF, in acute liver failure of DILI, non-specific treatment should be is the liver transplantation. And the specific treatment can be given in paracetamol-induced acute liver failure. Charcoal and acetylcysteine should be given, and also high volume plasma exchange. And this is our study in anti-tuberculosis drugs. In this case, the patients can be predicted to have maybe anti-tuberculosis drug if we know the age and also the acetylator status, with fast acetylator and slow acetylator, which in slow acetylator, these patients may prone to hepatotoxicity. So, dear colleague, in summary, DILI is a diagnostic of exclusion. The classifications is extrinsic, intrinsic, and idiosyncrasy. The clinical manifestation may be hepatocellular injury, cholestatic, or mixed type. Etiologic agent mostly can be identified if acute, and if chronic, this is more challenging. General management is to stop the suspected agent and support the organ function, and specific treatment available, but only for few drugs. Thank you for your attention, and I hope you can come to our country in October to Apostle Single Topic Conference in Bali, 11 to 13 October, for the new concept of portal hypertension and hepatobiliary malignancy related. And this will be conjunction with the Asian Conference on Tumor Ablations, ACTA in 2024, also in October in Bali. Thank you very much.
Thank you, Professor Ghani, for the very comprehensive overview of DILI, which sets the stage for our session now. Are there any questions for Professor Ghani? If not, then perhaps what we can do is we can take the question during discussion later on at the end of the session.
Okay, thank you.
Thank you.
Next speaker is Professor Hayato Nakaga, Department of Gastroenterology and Hepatology, Mie University, Japan. His title is Unraveling the Pathophysiology of Immune Checkpoint Inhibitor-Induced Immune-Mediated Hepatotoxicity through a Comparison with Autoimmune Hepatitis. Dr. Nakagawa, please.
Thank you. I would like to thank for this great opportunity to talk here. So this is my COI. Recently, immunotherapy has been much advanced, and also in HCC, immunotherapy plays a central role in systemic therapy. However, immunotherapy sometimes induces immune-related adverse event. It's called IRAE. And among them, immune checkpoint inhibitor, ICI-induced immune-mediated hepatotoxicity, we call it as IMH, is one of the serious IRAE. And IMH reportedly occurs in 0.7 to 60% of ICI treatments, and especially combination therapy of PD-1, PD-L1, and CTLA4 treatment has high risk. And mechanistically, healthy liver is in a state of immune tolerance, but disruption of immune tolerance due to ICI may cause IMH. However, detailed mechanisms of IMH are still unknown. I'd like to show a representative case of severe IMH. This patient is 40 years old. She suffered from melanoma. And after 2 cycles of anti-PD-1 antibody and anti-CTLA4 antibody, he developed hypophysitis, and he was treated with 80 milligrams per day prednisolone. After tapering prednisolone, he underwent 2 cycles of retreatment, but liver enzymes were markedly elevated, and that was corresponding to grade 3. So we increased again prednisolone to 80 milligrams, but transaminase level was continued to rise, so we added MMF. As you know, in most cases, MMF is effective, but in this patient, transaminase level was further elevated. To rule out the other liver disease, such as cytomegalovirus, we performed liver biopsy. And as you can see, liver biopsy showed marked infiltration of CD8 positive T cells and also CD4 positive T cells. So we could confirm this liver injury was caused by severe IMH. So we changed from MMF to azathioprine, and finally liver enzymes was decreased. So fortunately, this patient was improved, but sometimes IMH is life-threatening. Therefore, to elucidate the molecular mechanisms of IMH is very important. So this slide shows the presumed mechanisms of IMH. As you know, basically ICI exerts anti-tumor effect by activating neoantigen recognizing T cells, but blockade of immune checkpoint induces activation of self-antigen specific T cells in lymphoid tissue. And also tumor cell death releases not only neoantigen, but also self-antigen that induces further activation of self-antigen specific T cells. And this is considered to be one reason for high frequency of primary site-associated IRA, for example, pneumonitis in lung cancer patients, and also liver injury in HCC patients reported, I will show later. Furthermore, blockade of immune checkpoint induces also disruption of immune tolerance in the liver that further amplifies the hepatocyte injury. And this study showed the incidence of IMH in HCC is higher than other cancers. In patients with HCC who are treated with atezolizumab bevacizumab showed any grade of IMH was 11.4%, and the grade 3 for IMH was 4.3%, while in other cancers, any grade was 2.6%, and the grade 3/4 was 1.1%. And importantly, patients with any grade of IMH showed better prognosis. Therefore, management of IMH is very important in patients with HCC. And only very few reports, studies investigated the molecular mechanisms of IMH. And for example, this study showed aggregation of CCR2 positive macrophages and activated CD8 positive T cells in the liver tissue, suggesting interaction between innate and acquired immunity may be involved in IMH. In addition, recently, mouse model of IMH has been reported. And for example, this study showed, in this study, PD-1 knockout mice used, and anti-CTLA4 treatment did not induce IMH in PD-1 knockout mice, but combination therapy of anti-CTLA4 and anti-IDO1 treatment induces IMH-like regions in PD-1 knockout mice. So, ID1 positive dendritic cells suppress T cell activation by secretion of kynurenine. Therefore, inhibition of IDO1 induces further upregulation and further activation of T cells. Actually, in this mouse model, marked infiltration of CD4 T cells and CD8 positive T cells, suggesting T cells play critical role in IMH induction. However, detailed mechanism are still unknown. Here, so to elucidate the pathophysiology of IMH, we performed comprehensive molecular analysis using liver biopsy samples of IMH and compared them to those of autoimmune hepatitis, that is also immune-mediated liver injury, liver disease. So this slide shows the difference between AIH and IMH. And for example, a lower study showed periportal inflammation is dominant in AIH, while lobular inflammation is dominant in IMH and ZVHD. And the upper study showed plasma cell infiltration was very specific for autoimmune hepatitis, AIH, while histiocyte infiltration was observed in IMH. However, the difference between AIH and IMH are still unknown. So I'd like to, first I'd like to show about data about the AIH. As you know, AIH is a very old disease, but the molecular mechanisms of AIH still remain unknown. And most of the patients initially respond to corticosteroid therapy, but relapse is common regardless of continued treatment. So we are trying to elucidate the pathogenesis based on comprehensive expression analysis by RNA sequencing using liver biopsy samples. This is the clinical data of 85AH patients in our institute. Among 85AH patients, 90 patients experienced relapse, and 3 patients were resistant to initial corticosteroid therapy. And as shown in Kaplan-Meier curve, relapse was seen even 10 years after treatment. And the right panel shows the clinical parameters associated with resistance and relapse. And advanced fibrosis stage, more than fibrosis stage 2, was weakly associated with resistance and relapse. However, it was difficult to predict by usual clinical parameters. So we extracted RNA from liver biopsy samples of 85 AIH patients and performed a comprehensive expression analysis by RNA sequence. And this panel shows significantly altered pathways in relapse cases. And as you can see, inflammatory pathways such as interferon alpha and gamma and IL-6 STAT3 signaling and also TNF-kappa B pathways were significantly upregulated in patients with relapse. Therefore, patients with relapse already had significant activation of inflammatory pathways at the onset, although the transaminase level was similar between relapse cases and non-relapse cases. By the way, previously we reported gene signature reflecting the oncogenic potential from NAFLD. In this study, based on transcriptome on non-tumor liver biopsies from 48 cases of NAFLD HCC, we selected 133 significantly upregulated or downregulated genes in patients with recurrence. So we call this signature as prognostic liver signature. And as you can see, this signature clearly predicts the recurrence of HCC in this cohort. But interestingly, in other cohorts, HCC occurrence was predicted by this prognostic liver signature. So using a similar method, we generated AIH relapse signature consisting of 86 genes. And we selected 48 upregulated genes and 38 downregulated genes in patients with relapse. And we generated AIH relapse signature. And as you can see, this signature clearly predicts whether the patient will do relapse or not, like that. And now we are currently validating the usefulness of this signature using other cohorts. Furthermore, we performed integrative analysis with spatial transcriptomics Visium, and we mapped AIH relapse signature onto liver biopsy samples. And as you can see, high level of relapse signature located in periportal inflammatory area like that. Therefore, this kind of relapse signature reflect some specific immune microenvironment in patients with relapse. And using this data, we are doing further studying more deeply. So next, I'd like to talk about IMH. This is the main topic in this session. And in addition to 85 AIH patients, we analyzed 9 IMH patients who underwent liver biopsy for diagnosis. And as expected, serum IgG levels and the frequency of any positive level, positive patients were significantly higher in AIH patients. But there are no significant differences between these two diseases in other clinical parameters. And among 9 patients, dual ICI, including anti-CTLA-4 treatment, underwent to 2 patients. So next, we extracted RNA from liver biopsy samples of 9 IMH patients and performed integrative analysis with previous AIH data. And the right panel shows a principal component analysis. And as you can see, IMH and AIH have different gene expression patterns, so suggesting this study works well, and IMH and IMH has this information has some important genes involved in the molecular mechanisms of IMH. So next, we analyze the intrahepatic immune cell fraction by CyberSortX. You know, CyberSortX can predict the cellular composition from bulk RNA sequence data by integrating single-cell RNA-seq data as a reference. And we estimated the amount of the 22 fractions of immune cells and generated a radar plot of average cell volume in IMH and AIH. And as you can see, entire components of immune cells very similar between IMH and AIH, but some kind of immune cells were significantly different. This slide shows the detailed data of the previous slide. And overall immune cell number was similar between these two diseases. But as expected, plasma cell was significantly increased in AIH, while M1 macrophage and monocyte were significantly increased in IMH. That were consistent with previous reports. And also, follicular helper T cell and activated CD4 T cells were significantly increased in IMH. Therefore, CD4 positive, for example, helper T cell activation may be important in IMH induction. And we also analyzed several various kinds of cytokines and chemokines, and we found several cytokines and chemokines specifically upregulated in IMH. So hopefully these factors could be biomarkers for IMH. So next we performed pathway analysis by GSEA, and as you can see, various kinds of pathways were significantly upregulated in IMH. And among them, we are focusing on mTOR PI3 kinase mTOR pathway signaling. As you know, mTOR pathway plays a critical role in T cell proliferation, cytokine production, and cytolytic function. And PD1, PD-L1 interaction suppresses T cell activation by inhibiting the mTOR pathway. But inhibiting interaction between PD-L1 and PD-1 by PD-1 inhibitors such as atezolizumab or durvalumab upregulates mTOR pathway again and induces T cell activation. Therefore, hyperactivation of mTOR pathway in IMH is reasonable, I think. And this slide shows the ESMO guideline for management of IMH. And in this guideline, corticosteroid and IV methylprednisolone are recommended as first therapy. And in patients with refractory to these therapies, mycophenolate, mofetil MMF, tocilizumab, azathioprine, tacrolimus, cyclosporin, and anti-thymocyte globulin are recommended. But based on our study, mTOR inhibitors such as everolimus may be one candidate for treatment of IMH. And actually, now we can use everolimus against patients with liver transplantation. Therefore, now we are examining the efficacy of everolimus on IMH using mouse models. So in summary, IMH showed different types of inflammatory cell infiltration and pathway activation compared to AIH, suggesting specific mechanisms of IMH. And mTOR pathway may be a therapeutic target for IMH. Thank you for your attention.
Thank you. Excellent talk, Professor Nakagawa. Is there any question from the audience? Oh, please.
So Komori from Nagasaki Medical Center. I'm very happy to hear from you kind of the comprehensive study. But my question is a little bit trivial, but how do you think about if you compare the IMH and acute onset AIH, one of the subset of the whole bunch of AIH?
That's an important question. And I didn't analyze the AIH patients by discriminating the acute or chronic AIH. So I would like to analyze from your point of view. Thank you.
Okay. And the second one is, this is a daily session, so it's not central for your talk, but what I'd like to know about the relapse pattern of the AIH, the transcription signature. Okay. If we compare the adjacent, normal liver tissue and AIH tissue, okay, after the analyzing the cell signaling signature, something like that, interferon alpha pathway or beta pathway are already being known for the upregulation. So my question is, how do you think about the relapse pattern? Is just the reflection of the substantial increase of the kind of signaling pathway, or the kind of distinct pattern of
that's a very difficult question to answer. I don't know, but I think to tell the truth, we have another data about the recurrence of liver biopsy samples. So now we are analyzing the data. Therefore, I cannot show the data now. So I'm sorry.
I'm asking just because, if the substantial amount of the immune activation is the significant in a relapse cases, the increased amount of the initial introduction of the immunosuppressant is just the sufficient.
Yes. Yeah, I think so.
Thank you.
Please.
Dr. Manish from India, and my question is that you said that autoimmune hepatitis is quite old, but as far as history says that it was first diagnosed in 1960. So in comparison to other diseases, it is relatively younger, not as old as other diseases known since thousands of years. My question is that one of the cause of autoimmune hepatitis is drugs. Drugs also causes autoimmune hepatitis. We have recently faced this patient in our hospital, dapsone-induced DILI, but later on biopsy it was confirmed as autoimmune hepatitis. So it is very difficult to differentiate drug-induced liver injury from baseline autoimmune hepatitis. You have given very good insight between IMH and AIH, but how to segregate this is DILI or DILI-induced autoimmune hepatitis?
So you mean the difference between DILI and AIH or DILI and IMH?
DILI and AIH.
DILI and AIH. Okay.
DILI drug-induced AIH.
Yeah. So we ruled out the DILI as much as possible in this patient, and also according to the national criteria, we selected patients and diagnosed as AIH. But some patients underwent some treatment before the diagnosis of AIH, so we might completely rule out the DILI from these patients. Yeah.
Professor Nakagawa, you analyze the pre-treatment value, and did you analyze the on-treatment value, like duration of steroid or response to steroid?
Which do you mean? What do you mean? So
治療中のバリューを比較しましたか？治療前のをいっぱい出されてましたけど、ステロイド治療中の。
So the effect of the treatment response on the relapse.
And
we
duration.
didn't check it.
Oh no, okay. And in patient with hepatocellular carcinoma, we sometimes use a combination of ICI and anti-VEGF inhibitor. Did you check it, your patient?
So in these cases?
Yes.
So in these cases, various kinds of treatment were performed, for example, because these patients were not always HCC patients. So for example, anti-CTLA4 and anti-PD-L1 treatment against melanoma, or TKI and PD-L1 against renal cell carcinoma. Therefore, various kind of treatment were performed in these IMH patients, but significant accumulation of CD4 or CD8 positive T cells were confirmed by liver biopsy, so we consider that as IMH.
Thank you. Is there any question from the audience? No? Thank you, Professor Nakagawa.
Thank you very much.
It is a pleasure to introduce you Professor Dan Yok-Young, who is Senior Consultant of Gastroenterology and Hepatology Department, Medicine, National University of Singapore, who is going to talk about drug-induced liver injury in Asia-Pacific region. Thank you.
Thank you very much, Madam Chairman. I'd like to thank the organizers again for the opportunity to attend this exciting conference and also for the great hospitality. And I understand that the cherry blossoms has just bloomed today in Kyoto. So as this is the Delhi Forum, I have positioned my talk today on what do we need to build an Asian liver tox registry. I think this dovetails very well with the opening introduction and the second talk that was given earlier. These are my declarations. So I'll cover DILI in Asia, following up from what Professor Ghani has mentioned, the challenges of setting up a registry for Asian DILI, the algorithms that we can use to identify drug-induced liver injury in health record databases, laboratory threshold criteria for pharmacovigilance, and future steps for understanding the DILI in Asia, and so finally, summary. So you have seen this graph chart earlier highlighting the difference in the DILI between Asia and compared to the West, Europe and United States. I think the biggest difference that we see is that in Asia, herbal drug-induced liver injury is more common than conventional drugs in the West. And in fact, the West, if it's not the antibiotics, the conventional drugs, it is the health dietary supplements, whereas in Asia, we use a lot of herbal supplements within our own diets and also for cultural purposes. The relative prevalence of DILI from traditional medicines and dietary supplements is reported as follows, about 17 to 18% in Japan and China. Singapore and Korea, interestingly, reports very high percentage of almost 70%, while it's about 13% in India. Obviously, the threshold for reporting is very different, and also, so therefore, these are not directly comparable, but it shows you the range of DILI directly from medicine and dietary supplements. The problem, I think, of DILI in Asia is that there's a dearth of prospective studies. Most of these analyses are retrospective. And Asia, in general, tend to underreport cases which are not well worked up. In fact, in many places where there's no good access to medical care, some of these are not even reported at all. There seems to be a higher mortality in Asians, possibly due to the fact that there is a low chances of liver transplant in many places. Anti-tuberculous drugs, as mentioned earlier, is known to be fairly common in Asia because of the high prevalence of tuberculosis. And herbs are part of diet and culture, which even among us is part of our normal routine. And when we come to understanding DILI, DILI depends on reporting of all the cases that have been discovered so that we can compile a rich compendium to inform us what are the cases of DILI. Firstly, it is very difficult because as doctors, we know that every patient takes overlapping herbal dietary supplement, Western medicine, TCM, Ayurvedics, and this put together makes it very difficult for us to determine which is the agent that is responsible when you meet a case of a potential DILI. The access to care, as I mentioned, is a challenge. And in fact, DILI is made on the basis of the fact that you must exclude all other causes. But that means you need to do a full suite of investigations. And again, not many places have access to the full suite of investigation for exclusion. Professor Ghani has mentioned there's a lack of consensus for DILI diagnosis. And what we've seen earlier as a mechanistic classification of DILI, be it direct, indirect, idiosyncratic, is not directly useful to clinicians because if you don't do a liver biopsy, you don't even know the pathogenic process, it is very difficult to use it for clinical management. The retest reliability is also not that great. And in fact, even if you use some of the accepted norms such as the RUCAM scores, the inter-rater reliability is reported to be no better than half. In other words, between every two specialist hepatologists, there will be half the chance of disagreement that this is a drug-induced liver disease. And DILI depends on a good base comprehensive registry for reference to give you the track record that these drugs have been involved. And in Asia, we know that our herbs have got commercial names, they have got names in the retail market, they've got scientific names. It is very difficult to map them to say which are they really been involved in DILI before. And every drug preparation, every dish of herbal medication and every concoction has got multiple elements within it. And the herbs may be contaminated with chemicals, metals, mycotoxins, pesticides, and which is not just the herbs itself or adulterated with Western drugs, as we have seen very commonly in many of these preparations. So this makes it very difficult for us to pinpoint specifically which is the key agent that is responsible for the drug-induced liver disease that is present. So there's one good example here. So this is two databases of drug-induced liver disease from herbs and health dietary supplement. The first point to note is that you will see a lot of scientific name, for example, Polygonum multiflorum, and the first question is, I don't see this in real life. My patient is not going to tell me they have got a problem with this, they're taking this particular medicine. The second is that you will see things that are very common, for example, green tea extract, which I'm sure some of us drink every day. So how do we know whether these are the ones that's causing drug-induced liver disease or not? And this is common in both, even in the Western literature, as well as in the Chinese compendium for traditional herbs causing DILI. So in classification of DILI, as we have mentioned, so apart from the mechanistic approach, we can also classify it by the pattern of disease that we see, which is what the clinician probably finds is more useful, whether the patient is presenting as acute hepatic necrosis, bland cholestasis, acute liver failure, from which he can then do the necessary approach and clinical management. So most of the DILI we talk about is idiopathic DILI. Apologies for the typing here, is idiopathic DILI. And what we mentioned earlier in the second case was a DILI secondary to drug-induced autoimmune hepatitis. So still drug-induced, but the pathophysiology is really one of autoimmune hepatitis. And we do know that among patients who receive chemotherapy, we also see a drug-induced associated fatty liver disease, where they present with fatty liver, but is really drug-induced, very commonly seen in the chemotherapy agents. So this is what I alluded to earlier, in that we really need a good compendium of liver toxicity herbs for Asia, because this is where we see many of our patients. The liver tox Professor Ghani spoke about is one good database where you can look at Western medication. They do have a short section on herbal medication, but it is a very small section and certainly doesn't cover the gamut of herbs and dietary supplements that we see today. That makes it difficult because without a track record of these drugs or dietary supplement, you realize that you can't even do a proper RUCAM scoring. As you can see, it is one of the major components. It used to be 3 points, but that's been revised in some of the scoring method. And this becomes a big chunk of your clinical assessment, whether you're dealing with DILI or not. And without this prior reports of incriminating drugs, we are then operating in the blind, and patients may go back to repeat the same drug itself, and so the tragedy repeats again. And thus landing impetus for us to come together to try to create an Asian-based liver compendium of drugs and herbs that potentially can cause DILI. So how we tried to approach this was, number one, of course, depending on reporting is a weak proposal because not everybody reports DILI. Even if doctors try, they sometimes have difficulty making a definitive diagnosis of DILI for every individual case. With the EMR that is proliferating throughout the world today, we asked the question whether we can systemically scan the databases to pick up cases which are DILI, so we can pull this into a compendium to provide a basis for DILI herbs and drugs. And if so, what kind of algorithms are available and how good are they? So I had a pharmacy PhD students who worked on this approach and look at the first project she did was to look at the systematic review and meta-analysis of the algorithms used to identify DILI in health record database. And there are about 25 meta-analyses out there which have used various approaches. You can of course use the ICD code. So for example, liver-induced injury, diagnose DILI, where your final diagnosis on discharge can be DILI based on expert opinion. Or you could just look at just liver function tests, transaminases, bilirubin and ALP. But of course the question is, at what threshold do you decide these are significant? Excluding of other causes, you could use the acute or acute on chronic liver failure, because that's where one situation where cases are very well documented because they go into the transplant registry and you can then know whether they really have DILI or not. You need to cater for temporal causality. Sometimes the doctors enter this into the notes, sometimes they don't, but we do know that this is one of the key components that defines DILI. And generally, if you have pre-identified drugs, for example, anti-tuberculous drugs, amoxicillin, these are drugs that have a higher risk of DILI and helps you to focus your surveillance on whether how much DILI cases you're seeing. So this is the meta-analysis that we did, that after removal of all the low quality or overlapping studies, we ended up with 25 meta-analysis. And the summary of the findings is, number one, there is generally heterogeneity across all the studies. It's quite significant, so therefore a lot of heterogeneity, making it very difficult to summarize consistently. The overall positive predictive value of detection algorithms was actually low, about 14.6%. It is actually not surprising because overall, the prevalence of DILI or the incidence of DILI in contributing to abnormal liver function tests in the inpatient setting is not high. So the positive prediction value does depend on prevalence of the disease. So it is about 14.6%. And if you try to combine diagnosis codes with laboratory criteria, one would think that that would give you better degree of accuracy. Interestingly, only gives you a marginal improvement in the pooled positive predictive value from 14.9 to 14.3%. So diagnosis codes by ICD are not very useful for differentiating DILI and non-DILI cases. But studies that look at pre-specified drugs of interest generally have slightly higher PPV compared to those that just do general surveillance. So this is the forest plot here. So you can see that between lab and diagnosis code compared to lab only, the summary of the effect size actually is not significant. So lab thresholds are just as good as lab and diagnosis. But you can see that there are some studies that seems to do very well compared to the rest. But in summary, overall, on averaging out, they don't do very well. So including ICD codes were not much better than LFT elevation if became DILI. And even look at acute liver injury, so more significant acute liver injury versus patients whom we have labeled as drug-induced liver injury. Surprisingly, that was not much better as well in terms of the positive predictive value. So validating both ALI and labeled DILI did not improve the pickup. So while underlying that the clinical documentation is important, objective lab data and algorithm-based prediction is probably as good as anything else. Again, highlighting that some studies which seems to do better, and possibly these are ones where there's better clinical documentation of DILI in a more robust manner. We then followed up with asking the next question. So if medical database give us about 14.4% of predictive value, what algorithm criteria is most useful in scanning for DILI in a multi-ethnic Asian population? So this looked at our own Singapore cohort of inpatients for 2040 admissions with at least 2 liver chemistries done when they're inpatient. And we look at their normal range discharge summaries, and the algorithm excluded some 1,000 cases, which have found to have alternative cases of liver enzyme elevation. So we applied the 3 most common algorithm, the DEWG, the DILIN protocol, and the CIOMS. And in terms of the number that was discharged based on the different liver enzymes, you can see that CIOMS picked up the most number of cases compared to DEWG or DILIN. About 385 was shared between the 3 algorithms. Again, it is not surprising because CIOMS use ALT more than 2 times upper limit normal, so the threshold is a lot lower to pick this up compared to the stricter criteria of ALT more than 5 times between both DILIN as well as DEWG. When we compare the performance characteristics of DILI threshold criteria, you can see that in terms of the sensitivity, DEWG and DILIN is about nearly 50% in terms of sensitivity because they have a higher threshold for ALT. But CIOMS has reached a sensitivity of 74%. Again, because of a lower ALT threshold of 2 times, they were able to capture most of the DILI cases. So the DILI cases, the gold standard was actually reviewed by a clinical clinicians as well as a pharmacologist. And when they went through each case notes, we picked up the actual true DILI cases that have been achieved final conclusion. And then we correlated this to the initial inpatient data sets to see how well we predicted them. But if you look at specificity, then they don't do too badly. So achieving almost 94 to 97% of specificity in making sure that they are or they are not DILI. The negative predictive value correspondingly hits about almost 99%. Positive predictive value, not great. But if you're trying to rule out DILI, then these do reasonably well. When we compare the DILI threshold with additional rules, so my postdoc student put in 2 additional rules, and the first is putting at least 2 abnormal liver chemistry components during admission. And this is really because a lot of times when patients come into hospital with related sepsis, pneumonia, the first liver function test can be high due to non-specific inflammation or sepsis. So by having 2 abnormal liver chemistry, it gives you the chance of excluding some of these transient cases where there is a regression towards the norm. On top of that, if you put in 2 additional liver chemistry plus a liver injury keyword in your discharge summary. So along the way, the junior doctor who summarized the discharge says, this is a liver injury. You can then be a little bit more specific that there is true liver injury and the liver function test is not a non-specific elevation due to other conditions. And you can see that although the sensitivity remains about the same, the specificity goes up to 99.6%. So therefore, giving you fairly good and robust confidence that you've excluded the non-DILI cases, and NPV hits almost near 100%, which is quite sufficient for our purpose in terms of picking up all the cases of DILI from our medical records database. Well, so this has solved the problem whereby you can pull out all the potential DILI cases from your data sets. You can then pull out all the potential drugs and agents that could have contributed to this. The second step you need to do then is to find out, are these agents, have they been reported in the literature to be associated with DILI? And with the advance of AI, this has been a very exciting area where people can use AI algorithms to scan the literature to pull out all the reports that have been associated with DILI. So this is one publication in Frontiers in Genetics, where the group looked at the DILI dataset, the FDA dataset, and the CIDR dataset, and using AI to pull out these drugs that are found in these cases, they showed that they were able to build a DILI classifier with more than 94%, almost 95% cross-validation and 94% external validation accuracy, giving us a very robust tool of really trawling the whole internet and pulling out all the relevant DILI cases for comparison. So we are now at a stage whereby we are able to pull good cases from our inpatient records. We are also able to pull cases from the PubMed, and therefore we can then merge these cases together and to see whether these drugs have got track record of involved in DILI to give us a good compendium. We can of course re-challenge our patients, but this is not usually done, as Professor Ghani mentioned. We also have to test theoretically for chemical tests to the herbs for impurity. In Singapore, we can send this to the drug agency where they do a test. Unfortunately, it costs almost about $1,000, and the patient has to pay for this without direct benefit, but you know for sure whether there's impurity within the herbs that could have contributed to the disease. But I think at this point, the gold standard of truth is you need a plausible biology, and they will require the academics to bring these herbs back into the lab using a metabolomics, your in vivo, animal models and pharmacology testing to prove that these drugs are directly involved in hepatotoxicity before this clears the final hurdle that these agents are directly involved in DILI. So this summarizes the approach to DILI, integrating the clinical recommendation from AASLD. And the first step is you need a criteria for identifying DILI, which in this case, they have used a stricter criteria of DILI 5 times upper limit normal. One may argue that the SIOM's criteria of 2 times upper limit normal is more sensitive, but you could say that you really want to know the clinically significant DILI and not the mild elevation of DILI, which are probably clinically not too significant. Then based on the history, you can create the R ratio and look at the pattern of disease and search for the injury. So looking at the liver tox, PubMed, or from the Asian compendium, you can then pull out and cross-reference what are the likely agents that patients have taken and therefore could be incriminated for causing DILI. You have to exclude other causes, and if necessary, do a liver biopsy to prove that it is indeed a DILI case driven by the specific medicine of suspicion. And I won't talk about the treatment because this has been covered earlier. So in summary, we believe that we are at this stage in time with the advances in data mining, with the advances in AI, we are at the position to be able to build an Asian database for drugs as well as a herbal medication using the EMR data mining, criteria DWG, more than 2 times, using 2 liver function tests and liver injury data set, looking at the drug history to pull out what are the things the patient has taken, comparing this to the compendium of liver drugs as well as herbs that is within the Asia, relevant for Asia, that has been validated using the literature search, using AI machines, and then finally building the Asian liver tox that is useful for our purpose. So this is one example of what it may look like when we compile this Asian database. For example, Jinpuhuan, that is commonly used as a herbal drug. You will have common name for mapping. So based on both its retail name, market name, cultural name, you know what drug it is. What is the likelihood it causes DILI, the pattern you expect to see, and finally the outcomes that will help guide your management for this particular patient. So in summary, DILI in Asia is poorly reported due to lack of reliable comprehensive database. The AI machinery and the data mining techniques we have today does provide algorithm to build comprehensive DILI registry. And data mining and hospital EMR database provide a feasible way of building a catalog of clinically significant DILI, which are useful for vigilance, pharmacovigilance survey. The SIOM's criteria appear to be the most sensitive, but it is the DILI criteria that is probably more specific. And combining this with AI techniques to scan the literature provide an opportunity to create a compendium of drugs that provides for more data, more evidence-based approach to managing DILI in Asia. Thank you very much for your attention.
Thank you, Professor Dan Dong-Jung, for this interesting presentation. Any questions or comments for the audience?
Thank you very much, Yogyang. Just wondering, in the process of establishing this DILI database for Asia, does it take into account the incidence of DILI arising from drug-drug interaction, or in some cases, for rare occurrence, it may be due to the comorbidities that the patients are suffering from?
Thanks, Kip. So I think you raised very good points in that DILI is a lot more complex than what we have actually presented here. I think at first cut, we will just try to identify what are the agents that are incriminated. Second level cut is individual response may be different, and that's where we talk about cirrhosis may be different, gender differences. And then finally, the most difficult part is drug-drug interaction. In the current international registry, they are all based on single drug, and then if you need to check drug-drug interactions, there's a separate database. So I think if we want to look at herbs, that will be even more complex endeavor for us to understand those interactions there. Genetics, I'm not sure whether it will give us a short circuit to understand a little bit more, but if we're able to work out the pharmacogenetics that drive some of these interactions, that may be a bit more useful in shortening the process. Thank you.
Nice presentation. Just please tell how many drugs, herbs, and health products are registered. What is the actual figure in database registry?
Oh, okay. So from our first the meta-analysis and review of our own database, we have picked up about 4,000 drugs, herbs. But they are not necessarily the definite cause yet because they are just pulled from the data set. We still have to reference it against the PubMed registry to know whether they're there. Some of them are combination which we have not really separated yet.
It's quite surprising that general impression is that quite a few drugs cause drug induced in liver injury, but the list is in thousands.
Yes, it is also partly because we haven't drilled down into. So some patients may be taking four drugs and herbs. So sometimes we cannot be sure. We take 2 or 3 possible causes. So on the actual list, there are a lot of possible suspects, but if we map it to the PubMed data search, hopefully we can narrow this down a lot more.
Thank you very much.
Okay, I'd like to introduce the last speaker for this session. He's Professor Hiroteru Kamimura, who will talk to us about the analysis of international comparisons of drug-induced liver-related adverse event reports in FDA and the PM data databases. Professor Kamimura.
Thank you. Firstly, I would like to thank the Abstract Review Committee and the chairs to giving me a chance to present our recent project. My name is Hiroteru Kamimura from Niigata University. Today, I will show analysis of international comparison of drug-induced liver-related adverse event reports in FDA and PMDA database. This is my financial disclosure. This is the cause of acute liver failure in each category. In Japan, HBV is the top cause of the ALF. On the other hand, USA and the UK, the paracetamol is the top cause of acute liver failure. This is a diagnostic criteria for acute on chronic liver failure, ACLF in Japan. Patients with cirrhosis and a Child-Pugh score of 5 to 9 should be diagnosed as having ACLF in a deterioration of liver function caused by severe liver damage developed within 28 days after an acute insult. The severity of the AL patient can be classified into 4 grades depending on the extent of deterioration in organ function, including liver, kidney, cerebral, blood coagulation, circulatory, and respiratory function. Professor Mochida and Nakayama reports the etiology of underlying cirrhosis in 183 patients with ACLF and 318 patients manifesting disease condition related to ACLF in Japan. The top cause of etiology of ACLF underlying cirrhosis is alcohol. And then acute insult in 183 patients with ALF is most top cause is alcohol abuse. And today's theme, ACLF on DD is only 3.8% in acute insult on ACLF in Japan. So what is the key point of ACLF and DD today's theme? In all over the world, we can use HCC treatment middle and advanced stage. We can, hepatologists use chemotherapy, molecular target therapy, immune checkpoint inhibitor, and some country you can use traditional Chinese medicine. This is a timeline of FDA approval of systemic HCC treatments. Molecular target therapy and immune checkpoint. And recently, all over the world, a combo type of immune therapy can use in insurance. So the problem with ACLF and DD is systematic HCC treatment, mainly chemotherapy and immune checkpoint therapy. So this is the purpose of our project. This study analyzed the current trends of drug-induced liver-related adverse event in Food and Drug Administration adverse event reporting system files and Japanese adverse drug event report database data using medical dictionary for regulatory activist terminology, MEDODORA, and survey chemotherapy and immune checkpoint therapy. This is a number of internet users all over the world. From the International Telecommunication reported, over the 60% of the people use some internet item. And especially in developed country and youth, almost the people use some internet item. Migration to fifth generation mobile communication standards, paperless era is expected to arrive in variety of this field. And what is internet item? Mobile phone is over the 0.5% in the global. This is a FDA adverse event reporting system files. General consumer and patient can report this system. And immigrants, not only English, but Espanol can report this FDA DD reporting system. This report can use a public dashboard accessible on Android or iPhone. So we can report DD promptly from a smartphone from anywhere in the world. This is a FDA dashboard data. The report consists from easy formatted dashboard. It is updated every 4 months and is available for free. So we can pick up the DD to report for the name and insert this dashboard. We can survey from 1997 to recent data, cause product name, and the number of cases in each drug and percentage. And we can survey these reaction type, many type of named DD. And what year is happened, and the case of reporter type, who is reporting these DD reports, healthcare or consumer or other. We can get this data for free. On the other hand, this is a Japanese adverse drug event report database data. It is reported in Japanese. And there is mainly paper-based reporting system and difficult to report for the general consumer. But this data we can get the CSV file from 2004 and collect Excel for free. This is a summary of our project. Files and data, 2 big database. And we chose firstly 7 MEDODORA from 7 SMQ and 324 PT terms and a filter. And we chose the drug-induced liver-related adverse event reports from these 2 big databases. And survey top 3 ranking and 5-year annual change and who is a reporter and the rate of severity. This is a summary of our study. This is a we chose firstly we chose 7 standard drug categories in these 7 technical terminology, and secondly we choose 320 preferred term, which is reported as a DD. So this is a result. Total files reports is a number tenfold in recent compared to the 1990s. And especially a number of DD reports in the 4-fold cases is reported compared to 1997. The data is not so big rising in data. This is a top 30 drug-induced liver-related adverse events drug from 1997 to 2019 in files. Only 2 drugs, which is use HCC treatment, but top 3 is released in 1954 and 1965. It's very old drug, and light column is this drug compared to JADA ranking. And very old drug is ranking in the files data. This is a drug-induced liver-related adverse events ranking 1997 to 2019 files every 5 years. Warfarin and paracetamol and atorvastatin is constantly ranking in these 20 years. Compared to this is a top 3 drug-induced liver-related adverse events drug from 2004 to 2019 in JADA. Sorafenib, nivolumab, habartoxin, regorafenib, pembrolizumab, ipilimumab, lenvatinib, tegafuracil, which is used in HCC treatment, is ranking in top 3 ranking. And preference, since 2010, very new drug is ranking in this ranking data. Right column shows the compared to the files rank to JADA database. This is a drug-induced liver-related adverse events ranking 2004 to 2019 every 5 years in JADA. No drug is consistently ranking, but a new drug is coming up to this ranking. So this is a summary. There was no rank correlation for the top 30 liver-related drug adverse event in files and JADA drug-related database. Comparing to 30 items by year of release, files was found to have a median age of 1998, and JADA was found to have a median age of 2012, with JADA having more recent reports. JADA ranked number of chemotherapy, molecular target therapy, and ICIs, but it is concerned confirmation and reporting of chemotherapy, which is strictly evaluated in CTCAE. This is a classification of reported files. From 1968, we can get data, and recently, over the half of the reporter is consumer. It is why is OTC is widespread in USA, so the paracetamol is a top ranking in this data. Compared to this, the reported to JADA is mainly healthcare professional. As you know, this is a cause of submitted to PMDA as a post-marketing surveillance by companies. This is a classification of severity of files. Many cases, including this, and serious pattern is reported to files. Compared to this, JADA is non-serious or recovery cases is more than half. This is concerned after report. This is a summary. In files, half of the reports were from general users since 2014, suggesting that the online reporting system had an impact. Post-marketing surveillance reporting may contribute to ranking in JADA, even when considering severity at the time of reporting and outcomes after reporting. And next, this time in Japan, Benicoji is a topic in daily news, which causes a renal failure supplement. And our collaborator in Meiji University, Professor, investigated the DD toolbox, which is a assist in the outpatient treatment of herbal medicine and supplements using toxicity prediction tool for potential agonist-antagonist activity in molecular initiating events based on chemical structure, created using machine learning from a files database. We can get free this tool. This is a case, 70s female. She is attending clinic for dyslipidemia and hypertension. She has been taking Hange Kobokto, Seihaito, and iron-based supplements for the past 27 days. AST, AAT, and alkyl-phosphatase, and total bilirubin with flare-up. And DLT scores 80 points, and she was finally referred to our department. We performed the liver biopsy, and the fluorescence canalicula is positive, and severe portal inflammation is not exist, but zone 3 inflammation is existing. So we diagnosed cirrhotic type of drug liver injury she has. So which component of herb and supplements will not be allowed in the future? We can get from the data sheet some herbal medicine or supplement. We can from data sheet we can get a chemical compound. So this case analysis of main component in Hange Kobokto and Seihaito. Many type of herb, and herb compounds is a many type of chemical component. This. So we insert this chemical component to PubChem data. We can get the 3D stereo chemical structure. So next, we insert this chemical structure to this investigated toxic predictor. From the machine learning database. Insert 3D structure, predictor calculate agonist and antagonist reaction from 3D structure formula predicts possibility to cause of hepatocellular damage type and resistor and DIPT, drug-induced lung damage from machine learning in the database. So this is a result of this case. Orgon, including bicarin, and ninjin, including ginesoid, is a possibility of a positive type of cirrhosis toxicity. So this patient pay attention to this herb, and patient can use another herb, and iron database supplement is okay. So this is a conclusion. We compare the data on adverse events in the US and Japan were used to compare recently liver-related adverse drug events. An international comparison suggests that rapidly of the reporter and reporting form using mobile device may have contributed to this. Toxic predictor created from files database can be used as a tool to support outpatient care in identifying causative compounds, herbal medicine, and dietary supplements. This is my collaborator. Thank you for your attention.
Thank you very much for the interesting lecture. Are there any questions?
Professor Kamimura, thank you for excellent talk. I have one question. I can see the your table, in your table, traditional herb, NSO or something. Can we register the herbal medicine FDA not approval like Benicoji?
Thank you for your question. In JEDA database, herbal toxin is ranking in top 30, but files data is not herbal is not ranking because herbal is a total name, and I guess files is divided into component of various herb. So Dr. Konda's question, and Benicoji consists of many compounds, and this recently it is a problem toxin from the fungus. So it is already reported to files, so we can guess the toxicity about the renal failure in Benicoji, but this stolling caused by fungus is not reported to, I guess, liver toxicity. So this toxic predictor we useful in this guess. Benicoji is cause liver toxicity.
The situation of United States US database is similar to JADA. We cannot register the FDA does not approve drug.
I don't know the approval drug. Yeah, Benicoji is not approval drug. I don't know.
Thank you very much.
I think we have 5 more minutes. Can we invite the speakers to come forward for the very short discussion? Professor Gani has go off. Professor Nakagawa. Okay, it's gone off as well. Is Dr. Diana Payawal the discussant around? No, she's not. Okay. Okay, I guess we'll just discuss from us here. Professor Kamimura, can I check, when people report to JADA, does it go to the regulatory authorities for every case, or is this just a database for subsequent follow-up?
Follow-up.
Yes. Does the regulatory authorities look at every report and assess the drug for whether it continues to be can be sell? Yeah.
Like the files database, JADA is renewal in 4 times in year, so we can follow up new data in JADA.
Okay. Are there any other questions from the audience?
Question from audience.
Is there a difference in the use of warfarin between the US and Japan that explains such a remarkable difference? Is the liver-related adverse effect reported to FDA actual LFT abnormality, or does it include bleeding events?
Okay. One more time.
Okay. So first question is, for warfarin, between US and Japan, there is a big difference in the reporting. And is it because the report in FDA is really liver abnormality, or is it bleeding events because of warfarin? Warfarin causes bleeding.
Warfarin.
Yes. So, but say Japan and US very different.
I show the top 30 ranking in this session. Warfarin is within top 10 in files, but warfarin is very old drug, so JADA is ranking out of 30, out of ranking in JADA.
So is it because both the two database, do they use the same criteria of DILI, or warfarin is also from bleeding?
Not so same criteria. Because Japanese, JADA is reporting in Japanese, so we exchange Japanese to Medodora English term. And the files is originally reported in Medodora. So JADA is not firstly reported in Medodora, Japanese language. It's not so same criteria.
Any further questions? Okay, if not, then just leaves me to thank Professor Kamimura and also all of you for attending this session. I think next is the poster session. Thank you and have a good evening. Thank you.
Thank you very much, the moderators and also speakers.